started, you guys, only because, like I said, we have so much going on, and we are really excited today. Like I said, we have Dr. Aimee Moulin, and she's going to give us a MAT update. This is the Navigator Training Focus Series. And of course, we always acknowledge that we are part of Public Health Institute, and we will share our slide deck and all of the links to today's training in a post-event email, so you don't have to worry, or we will send this to you as long as you are registered. And we have nothing to disclose. If we say any type of trade names, that's only because that is what we present. We do not work for any of those other companies. So today, just make sure the biggest housekeeping item is address your question in the chat to everyone. Sometimes it already pops up to host and panelists, but we want everybody to see the questions, because believe me, if you have a question, somebody else probably has the same one. So again, please make sure that your chat is addressed to everyone, and please put your question in the chat. We will call on you if we need clarification about your question. So we are happy to be here. And you guys know that our goal, and I always like to go over the basics, we are California Bridge, and our goal is simple: 24/7 access to high quality treatment of substance use disorders in all of California hospitals by 2025. We got one more year to go. It's change for this big, huge goal, but I think with you guys in our on our side, we will definitely achieve this, because you guys are amazing. You're the ones that are driving this. So as every training, I always like to go over the CA Bridge model. What is it? Well, you know that we're revolutionizing the system of care, and it is a three-process, three-focus, and the first one being low barrier treatment. That's what your docs are doing in the ED by prescribing medication for addiction treatment. The other two pillars are connection to care and community. That's what you as a navigator are doing when you refer and navigate patients for treatment, using a warm handoff, right? And then the last is a culture of harm reduction. That's your naloxone projects, and so many of you. It's been wonderful to hear. We've been on a road trip, and to hear your harm reduction projects, and that has just been amazing. So that's our three pillars of success that you guys are carrying out in your hospitals. So we have a few announcements before we get started. I did mention we're on a road tour, and we are doing Navigator regional workshops. And our last and final workshop is in Sacramento, March 28th at UC Davis. We will be visiting Dr. Milan's area. So we're really excited. Please hope you can join us. Again, this is our last one for this round of funding. We don't know what's in the future, but for right now, we've been all across the state, and these are really great networking. If you guys want to network and talk to other navigators, this is a great opportunity. We also are offering a nurse fellowship. So if you have nurses that are involved, or just advocates and are really cheerleaders for your program, please refer them to our nurse fellowship. And that's the information. And we'll supply the link on the post-event email. And then last, we started a new pilot project for a navigator peer support. Our navigators really wanted to have a kind of a formal but informal space for us to share experiences, to kind of debrief and de-stress from all of this stressful work you do. We know it's very much challenging. So please join us. And this is strictly confidential. It's a great way to kind of just, get rejuvenated and definitely clear your mind among your peers. So with that, we're going to get started. These are our objectives for today. So if you are here for your CEUs, for CCAP or CADAP, we will be supplying that with an evaluation that will be sent out in our post-event email. Well, I'm happy to turn this over. For those who don't know, this is probably the biggest, um, working with Dr. Milan has been wonderful. Let me let you know why. She is, if not the leader of the Navigator fan club. Um, I say that wholeheartedly. She is doing so much behind the scenes to advocate. She is just one of your biggest fans. If you don't know Dr. Milan, and you'll know why in a second. Her heart and soul is helping people with addiction. She is a professor at UC Davis as well. She's emergency medicine medical doctor, and she is the chief of the Division of Addiction Medicine at UC Davis. And she is just wonderful, founder and creator of CA Bridge. And with that, I'm going to hand it over to Dr. Aimee Moulin.
Thank you, Sherry. And I just thank everybody for having me here. I'm really excited to be here with the Navigators because, as Sherry said, you have made this happen. And when you go back to that goal that we set of every hospital in California by 2025, I have to be honest with you, it was a big reach goal. And you have made that happen. I mean, we are really almost there. I think we're approaching 90% of the hospitals in California. So just want to take a moment to thank everybody on this call for what you have done and what you are continuing to do, because we're not done. So thank you all, and thank you for having me. We're going to talk today about medications. I really want to kind of take a moment to recognize what you've done, but also this is for you. So please feel free to interrupt me, ask questions. This is your session. Also, you know, as an emergency physician, we all work in the ER. Interruptions are a part of my life. And so if you don't interrupt me, I'm going to feel not at home. So please, we're colleagues and friends here, interrupt me, ask questions. So what's happening at California Bridge? We are in a process of celebrating you and all of our accomplishments together, but also looking forward. Specifically, you know, the drug supply has changed, how we're treating people have changed. And so we're really trying to keep up to date on all of those protocols, which is another piece to talk about today. But also we're launching another round of funding for those navigators who are not sustained yet by their hospital. And then we're going to spend the next year and a half really digging in and making sure that our navigator team is supported in all of their hospitals and their work, so that we can really keep the momentum and change going. Next slide. So this is, you know, a moment to celebrate. This is our impact to date. Over 300,000 people that we have reached in our hospitals. And all of these folks that we have really identified with opioid use disorder, and been that linchpin to provide them treatment. It's really impressive what you have done, and it really just proves the huge piece that you have in the role that we have to play in providing access to care. This is the other piece that I always want to highlight that I think we all need to talk more about from this data. What I find most remarkable, one is the breadth, but also there is a myth out there that people with opioid use disorder, that people with substance use disorders don't want help. And so the piece that I always want to highlight here is, you know, of the 240,000 people that you have identified with opioid use disorder, almost 100,000, so a good percentage of them, want help and want MAT that day. And so really by providing that culture of harm reduction, that low barrier access, we're really making a difference to people who need it. So thank you. Next slide. So we are launched a change to our buprenorphine quick start guide. This was in response to a lot of your feedback, to the changes in the drug supply, to a recognition that we are needing to kind of adjust and provide that real-time guidance, which we think is really important at California Bridge, to make sure that folks are getting treated in the best possible way. Do we have the quick start guide that we can put up? Okay, so this is the new guide, and this is what I want to talk about, and I want to hear your questions. So really what we have done is we are increasing the dosing. So we're having folks can start right out of the gate with 16 milligrams. So really kind of upping the doses. And we're seeing most people stabilize not on 16 milligrams, which is 8 twice a day, but those higher doses of 24 milligrams, 8 3 times a day. And I want to pause here and see what questions you have. What is this bringing up for you? Is this true to things that you are seeing on the ground? And what are you thinking about these higher doses? And also would love to hear about ways that we can help to educate folks that the higher doses of buprenorphine are helping folks at this moment, and how we can really continue this education.
Hey, so Aimee, I have somebody, one of our navigators saying doctors are very reluctant to give higher doses. This is
Yeah.
something we've heard a lot of, right?
Mm-hmm. And I think that this is a challenge. So just so you know, the original guidance from the FDA on buprenorphine has starting doses of 2 to 4 milligrams, which we all know just doesn't work. Did not work for heroin and really does not work for fentanyl. And so these higher doses, I think, are new, they're different, but it's important for us to be able to respond to fentanyl in a way that is patient-centered. So we updated this guidance to kind of allow folks to realize that those higher doses are safe, but change is hard. So I hear you. And I would love to know what strategies you think are effective for us to kind of get the message out that with fentanyl, we really need to start these higher doses, but also higher doses are safe and that we can go ahead 30 to 56 milligrams. And so this wanted to highlight to you that this has changed. So as you're seeing people treated, you can direct them to this updated guide, and that might help folks feel more comfortable with these higher doses. Also, the discharge doses, we're seeing, 24 milligrams being the norm for daily dosing, so 8 TID, but it doesn't really matter, right? You can do 24 milligrams once a day, you can divide it twice a day, you can divide it 3 times a day. One of the ways that I always try to make sure, even if someone thinks they'll only need 16, I still write for 24 and say the additional one can be a PRN dose. And so that they also won't run out, because that's a key piece, is I don't want people to run out and then have to try and get an early refill.
Okay, so I've got some comments here. I'm going to read to you, Aimee. Some patients who've used bupe in the past actually have stated that they're comfortable at higher doses of bupe. They know what works for them, and it's nice when some doctors are understanding and open to helping increase. There are some cases where some doctors have been hesitant, stating they've already increased the dose. This guide can be helpful. Now we get something to show them. So it's what we are. It sounds like the quick start is being accepted. Just take some time. And for the person that asked the dated revision, the one that's on our website is the most up to date. So if you're on our website, that is the one that is updated. Another question, comment, most of our patients come in intoxicated currently or with last use less than 12 hours ago, making it hard to get docs on board to start right away.
Yes, so this is the other change that we have seen with fentanyl, is that there's those longer times to withdrawal. So unfortunately, we see where fentanyl takes longer to wash out. I'm missing the old days of heroin when we could time the withdrawal and it was faster. So we're seeing people wait 36, 48 hours before they're in withdrawal enough to start with high dose buprenorphine. I think the next thing that we're going to work on updating is the self-start guide, because I think being able to discharge patients so that they can do that self-start at higher doses with longer time periods is going to be important with fentanyl. But yes, I think this is a challenge. Other strategies are educating your patients on when to come in, that they're going to have to wait a little bit, educating them on when to come back if they want to be administered in the ED. And then I think a lot more education we're going to have to do around self-starts, because we are seeing that people need to wait longer before they can start those high doses.
Great. Thank you. Thank you for your questions and your comments. You guys keep them coming. So I have another question. Most of our doctors give Bupal in ED, but discharge with Suboxone. Is the dosing the same?
These are great questions. The dosing is exactly the same. So there's Subutex, which most places are giving in the hospital, is only buprenorphine. That tends to be what hospitals have on formulary. So you tend to give Subutex in the ED. There's a lot of prescriptions for Suboxone. So Suboxone is a combination of buprenorphine with naloxone. The naloxone in there, I think, is a marketing ploy, because the naloxone is inactivated unless you were to crush and inject the buprenorphine, the Suboxone. The thought is that it decreases diversion or abuse of Suboxone. But as we all know, if you crush and inject buprenorphine, it does not magically become heroin or fentanyl. It is still just buprenorphine. It is still just a partial agonist. So if you crush and inject buprenorphine, it just has a shorter onset. So that is really just a marketing ploy. It's not necessary to have Suboxone. There's no reason not to prescribe Subutex, other than some insurances, and I think including Medi-Cal, are only covering brand name Suboxone. So really what I say is whatever works for the patient and they can get access to, that is what I prescribe. But great question. I also want to say kudos to you all for bringing these pieces up to us, because a lot of the information that we were getting and the feedback from our Navigator team were what drove these updates and what keeps us making sure that we are responding to what you're seeing, so that we're providing guidance that is working for you and for our patients.
Okay, we have another comment. I will usually, from Wendy, our mentor, I usually advise to not use after 9 p.m. the night before, to come in the morning when they wake up, instead of using if the patient has to come to the ED after using an hour or two before checking in. That's great, preparing them for what's going to happen, right? Rather than, so when you have that call and they call you, you do have time to do that. So great comment, Wendy. So just let me, I have had a patient not want Suboxone because if they were to relapse, he would have to wait to use it again, or otherwise face precipitated withdrawals. Now, if they want Subutex in my neck of the woods, it is a lot harder. Not as fast, but because they have to go through a PCP instead of a regular MAT clinic.
So I can't speak to why they're making them go to the PCP, but Suboxone and Subutex are functionally both buprenorphine. They really are just different formulations of the same medication. So they should be able to get either one prescribed. Both of them are able to be prescribed, and both of them act the same. So with any buprenorphine product, Suboxone, Subutex, there is the risk of precipitated withdrawal if the patient hasn't waited long enough. But generally I feel like whatever the patient is going to take, that is the right medication. So if I have someone say like, I need Subutex, it's fantastic, let's give you Subutex. Someone feels like they need tablets or they need strips, whatever they feel works for them and they can get access to rapidly and easily, that is the right medication. So I just want to reassure you that Subutex, Suboxone, it's functionally the same.
Great. These are great questions.
These are fantastic.
Yeah, I love this because, like I said, if you're not putting something in the chat and talking about it, probably you're speaking for about 5 or 10 people already. Because I know we hear the same questions, and sometimes it's better to hear in a different way, a different presentation. So keep them coming. Before we move on off the quick start, I'm going to linger a few more minutes, just a few more seconds here. Any other questions about the quick start before we move on? There will be time, in the end for more questions and answers, but right now that we're here. So we can give them Subutex here in the hospital and supply a 10-day script, but my fear is going through the PCP and it taking 2 weeks.
Yeah, yeah. So if you have longer periods to connecting folks to treatment, I try to get folks to prescribe longer durations from the ED and from the hospital. So some of our patients, we are prescribing, 2-3 week prescriptions just to make sure that they have continuous access to buprenorphine.
Yeah, and Aimee, that's something you've recommended, even before I came here, is the longer the better. So that way they don't have to stress and worry about missing an appointment or getting rescheduled. They have a few weeks to get into that appointment and make transportation. It sometimes it can be challenging to just to show up. So having that foresight and that leadway flexibility with 2 weeks or more is always advisable. That's great. Well, if there are no more questions or comments, Aimee, you want to move on?
We'll keep on rolling. We'll keep on
Okay.
rolling. We will try to get to everything, but if we can't, maybe we'll plan another session. Keep going.
Okay. So we want to know, this is our next topic, and
Yep.
Dr. Moulin, what to consider.
Okay, so here's the other strategy. So the strategy that we've most been using is this weight withdrawal, megadose, macrodose, quick start buprenorphine. That's the one that we just went through. But what if your patient does not want to go through withdrawal? Or actually, this is a patient who is admitted to the hospital. This is a fantastic strategy. It's called microdosing, but really what we want to think about this is a cross taper. So this is a patient who is still either in the hospital getting OxyContin, Dilaudid in the hospital, while we slowly give them buprenorphine and slowly increase their exposure to buprenorphine. Outpatient, what happens here is the patient who's continuing to use, but then slowly increasing their buprenorphine exposure. We do have some cross taper. I don't know if we have the cross taper protocol done, but it helps to guide like how you can still be exposed to full agonist while we then slowly ramp up their buprenorphine exposure. A little bit more complicated, works really well if you have a patient in the hospital for 3-4 days. So if someone has been admitted, if they have been a trauma patient or if they're admitted for pneumonia, and they can be given full dose opioids like OxyContin, and then we slowly ramp up buprenorphine. Questions on this?
I do have one here, and what it says is, I've had a few patients without Medi-Cal and had to just prescribe quite a bit bup until Medi-Cal could kick in. What about methadone?
Okay, so methadone is the other strategy. Methadone, we can't prescribe for opioid use disorder. For methadone, you have to be administered. So you can administer methadone in your ED, you can administer methadone in your hospital, but outpatient, we need to connect folks to a methadone clinic so they can continue to be administered methadone. We do have a methadone start that we have linked on the California Bridge website that you can use for clinicians who are starting or continuing methadone through the ED. So methadone can be administered in the emergency department. You can have people come back to the emergency department for repeat dosing until they can get into the methadone clinic. And some EDs even can dispense up to 3 days of methadone. So to bridge that patient until they can enter into a methadone clinic.
Great. And then
Great questions.
these are great. And Chaya just put in the microdosing and cross tapering resource. It's in the chat. I have another question. What about, I'm talking about microdosing methadone.
Oh,
Yeah.
okay. So the reason that we microdose buprenorphine is because buprenorphine is that partial agonist, so it can cause someone to go into withdrawal. So the idea of microdosing is that it's that cross taper where the person still has the full agonist, and then we slowly sneak the buprenorphine in there so that they don't have to experience that precipitated withdrawal that sometimes happens if they don't wait long enough. Methadone is full agonist, so you don't actually need to microdose methadone because there's not that risk of withdrawal because it is a full agonist, so there's not the same risk. So generally, you can just start methadone, and then we do have a methadone guide where you can increase the methadone in the hospital or as you're bridging them to a methadone clinic.
Great
We
question.
also have the methadone quick start. Mm-hmm. These are
Awesome.
fantastic questions. Thank you all.
I'm gonna skip. We don't. There's a question here about Bridget's perspective on Narcan versus OPV. That's if you want to reach out to Dr. Moulin later, please. Why don't you send us an email? We're not going to have time for that today for that discussion. So please reach out info@bridgetotreatment.org if you want some more information about that. The next question is, would that be 1 to 2 milligrams of buprenorphine? Regarding sneaking,
Yes. So we have in the So we have in the microdosing protocol how to kind of cut your strips so that you can quarter the strips. You can get down to those low doses of buprenorphine, and that should be on the microdosing protocols. There's other strategies that can be used in a hospital where sometimes they'll start a Butrans patch in the hospital to help microdose, or other formulations that are used for pain, not for opioid use disorder, like Belbuca, which can get you those low doses. But generally what you'll do is you can kind of cut the strips. You can cut them and quarter them, cut them in half or quarter them to get, the low doses of buprenorphine.
Great. I love this interaction. This is awesome, you guys. Like I said, no bad question. These are all so good. I have a comment here.
And
Go ahead.
Oh, I was just going to say your questions are great. And then also, as you bring things up that you see clinically, it helps us to be able to respond to it and make sure that our guides are updated and that we're providing you what you need and what our patients need.
Yeah, this is like real time. This is like ask the doc here time. Definitely. So it looks like somebody's expressing some frustration with the prescribers. Why don't the providers not know the composition of Suboxone and the safety feature of naloxone, which prevents overdose and abuse? It appears they are not getting the updated information through the required education. Are we updating the ED staff?
Yeah, I think that the naloxone it's inactive. The naloxone in the Suboxone is inactive. From my perspective, it's really not that important. But it's hard because there's a lot of marketing from the drug companies, so people sometimes have misperceptions that we kind of have to overcome. But yeah, I hear you. I think it's a little bit complicated pharmacologically, and also, we got drug company marketing saying that it's important when maybe it's not.
Absolutely. Like I said, all of your comments and questions, there's no bad ones, because again, we all have probably the same questions, curiosity, and it may stimulate another question. So keep them coming. Roger, I wish we could talk. We can get you info@bridgetotreatment.org if you have more questions, Roger. There's no problem. So Rudy's saying the quick start methadone guide came in handy last night because a provider was not too comfortable administering administering, but I politely said, if you don't believe me, here's the guide. I love that. That's awesome. So it's working.
Love it. Thank you so much. That's fantastic. Yes. That's what we're trying to do, just sort of bust through some myths and help people feel safe.
Yeah, and somebody mentioned they were preparing to study a Belbuca cross-tapering protocol for our street
Mhm.
medicine program.
Love it. Love it.
Our hospital does not do methadone, strictly bup and Suboxone. All right. That's, thank you. And that there's nothing wrong with that, right, Dr. Milan?
I think buprenorphine is important. And so wonderful that you are doing buprenorphine. I like being an access point for methadone because there are some patients who benefit from methadone. But, as long as you have some options for people and then can link them to methadone clinics, to think that you can only do what you can do, but it is nice if they're able to provide access to both medications. Some people do better with methadone.
All right.
But, we all try and, we're moving forward one step at a time. I try to have a harm reduction approach to my hospitals too, and just meet them where they are and try and keep moving them forward.
Absolutely. I think that's all of us, right? I love that. Love that
Yep.
final on here. Okay. So any other questions regarding cross tapering or micro dosing? Before we move on. Okay, so I'm getting a few more questions in the chat. Give me a second to catch up here. I hope people already on methadone get methadone. Yes, absolutely. We feel that same. Yes, we can't transfer them in the emergency room. So definitely we hope so too. I do provide referral for those requesting methadone. Great. That's just as, we're meeting them, doing what we can. Justin, if withdrawals are not as notable yet, their cows is pretty high. Would it be okay to start bup right away in a regular dose, or would it be better to do this microdosing? Last use was 40 hours ago.
Okay, so if the patient is in withdrawal and they have a cows that shows that they're in withdrawal, it's been 48, that is a good moment for the quick start. So the microdosing is for someone who has not stopped using. So if your patient is already in withdrawal, it's been 48 hours, you have a cows that's 9, 10, 11, 12, go ahead with the macrodose quick start. The microdose is for someone who's not yet in withdrawal, and or that patient who has a trauma patient who's come into the hospital who's going to be on full agonist for pain. So if there's a patient who's in the hospital, we do this a lot at UC Davis with our burn patients. They come in, they're on Dilaudid, fentanyl, OxyContin, and then we sneak that buprenorphine in while they're there, so that by the time that they're discharged, they go home with only buprenorphine. So it works really well for the person who's not in withdrawal or has a co-occurring pain condition. They're in the hospital, or even if they want to try this fancy cross taper outpatient. But for that person who's made it to 48 hours, who has a high cows, I would go with the quick start. Great
Awesome.
question.
Yeah.
Thank you.
Absolutely. Like I said, they keep coming. Here's a side question. Potassium along with Suboxone dosing. What is the protocol, or is there a protocol to assist with beginning stages and or with the withdrawals?
I have not heard of potassium protocols. I don't think that buprenorphine impacts a patient's potassium level. So if someone had incidentally low potassium that the doctor wanted to replace, they can, but it's not necessary. It's not something that you need to do routinely.
Perfect. Thank you. All right. Are we ready to move on? Okay, guys.
What's next?
We have the newest trend. We've get a lot of questions about this. So many. Xylazine.
Yes. So xylazine is very interesting. So xylazine has been primarily a veterinary tranquilizer. It's primarily an alpha-2 drug. It kind of works like clonidine or dexametasomidine. These are other drugs you might have heard of. It's a sedative. It is very popular on the East Coast in Philadelphia and is thought to be associated with poorly healing wounds. We are planning to schedule a webinar with one of our xylazine experts from Philadelphia who has a ton of experience with xylazine. We're watching in California. We have not yet in California seen a lot of xylazine through the Poison Center. They've been sending out samples, and there's been a little bit of xylazine, but not widespread yet. So I think it is something that we want to know about, that we want to be prepared for, but fortunately has not fully hit our drug supply in California yet. But would love to know what you guys are seeing, and just know that we are planning to have one of the experts of xylazine from Philadelphia come talk to us. Happy to answer questions there.
All right, you guys, any questions? I know this is something we always get when we have any type of trainings. And if you have any questions about the xylazine, like Dr. Moulin said, we are planning a training in the next couple months with the expert. Thank you, Dr. Moulin, for the referral, because we want you to have the most updated information about xylazine. Going back, if there's no questions about xylazine, I'm not, we have one question that says, does I guess buprenorphine Suboxone work on patients using ISO?
I'm not sure what ISO is.
Okay, so
You want to clarify?
yeah,
And you guys are going to teach me.
looks like Rosemary, can you please let us know what ISO means?
As long as it is a opioid, buprenorphine should work. So if it's a type of opioid medication, even kratom, any synthetic opioid, buprenorphine should work. Even, I don't know if you guys see folks who are using kratom as a way to get off and then have escalating doses of kratom, you can use buprenorphine for those too. You can use buprenorphine for people who are co-using fentanyl and meth. The buprenorphine works great there. I would also recommend at those points if people can be on the injectables, which are really fantastic.
Okay, so will there be an email invitation for the training? It will be on our website, and we will have send out announcements for all of our trainings. We do send a monthly newsletter. So if you're not on our mailing list, please email us at info@bridgetotreatment.org and get on our mailing list. Okay, Rosemary's looking for the spelling. Lynn says we have just recently seen an increase in positives for xylazine here on the Mendocino coast, Fort Bragg. There are some
Xylazine. Go ahead.
Okay, there are patients who state they are using ISO. They say it is stronger than fentanyl. Do you mean fentanyl?
Oh, this is probably like a isofentanyl, carfentanil, remifentanil. Yes,
Okay,
buprenorphine works for all of the different types of fentanyl. Yes. Yes, I hear you.
Okay, so
xylazine is not an opioid. It is a tranquilizer. It works through the alpha-2 pathways, which you don't really need to know, but it is not a opioid. However, from the few samples that we've had that have been positive for xylazine in California, they've also been positive for fentanyl. So we don't have patients who are just using xylazine yet in California. So I would still recommend buprenorphine, because the handful of samples that we've had test positive through Poison Center have also had fentanyl in them.
Great questions. And I see Roger's stating he's seen fentanyl causing low potassium with our patients. Aimee, would you?
Yeah, I could see, yes. I think that some of our patients are a bit malnourished. I mean, we see this with alcohol use disorder, who are, their nutritional status is not where we'd want it to be. And so you might see patients have electrolyte abnormalities, low potassium, primarily due to nutrition status. But the buprenorphine itself does not cause hypokalemia, and the fentanyl itself does not lower your potassium. But certainly we do see patients who, have poor nutritional status along with some of the other, social challenges that they have. The way that our society treats people who use drugs, they tend to have other social challenges and have other social needs. And so you can see low potassium because of that nutritional status, but it is not a side effect either of fentanyl or buprenorphine.
Perfect.
But really fantastic questions, and I appreciate you for bringing that up.
Yeah, I'm learning today too. So to clarify, John wants to know xylazine is a sedative, not opioid.
Correct. It is a non-opioid sedative.
Yes, it's non-FDA approved for animals is what Roger puts. Okay, so
it is not supposed to be used in humans.
no, not at all. So Dana has another question here about microdosing. Will that algorithm work for pain management?
Okay, so yes and no. So buprenorphine is used for pain, and a lot of pain physicians will use buprenorphine for pain. They tend to use different doses for pain than we use for opioid use disorder. I really love the microdosing protocol for my hospitalized patients who also have pain. So we have a fair number of patients who use fentanyl regularly, who also experience trauma, who also experience burns, who are admitted to the hospital and have both pain needs and an opioid use disorder. For those patients, it is really nice when we can use one of these microdosing protocols, treat their pain, and then in the process, swap them onto buprenorphine so that on discharge, we're discharging them on buprenorphine, which does work both for pain and for treatment of the opioid use disorder. If you have a patient who has only pain and not opioid use disorder, I generally defer those to the pain specialist. But yes, buprenorphine works great for me.
Great. Thanks. I have another question. Justin is asking, Trank is xylazine and fentanyl mixed together? Question mark.
Correct. Yes. Some places Trank is just xylazine.
Okay. Aimee, are you back? I think we lost Aimee for a second.
Sorry, I just got kicked out. Am I back?
Yes, you're back.
Me?
Awesome.
Okay, great. Great. Thank you, guys.
Okay, so I have a few more here. I've seen some cases where patients have abscesses all over their body. Yes, it does cause wounds. And so what about the rumor? Wendy wants to know, what about the rumor that long-term use of Suboxone causes tooth deterioration? There is a lawsuit going on. I do homeless outreach as well. I was asked about that in the field.
Yes. So there are some small studies that show buprenorphine can cause more gingivitis, primarily because of the frequent use of the films. But also there's some issues around also potentially due to the frequent use of the films and then a inadequate nutrition supply and sort of lower immune system. So it's not clear entirely if it is the buprenorphine, if it is the film, or if it is some of the other social determinants that folks are experiencing. But I do think one of the things that we can do is to try to make sure that folks have referral to dental care so that they can have adequate dental care, because we tend to see, some of these social determinants that our patients experience can also have adverse health outcomes. Poor dental care tends to be one of them as well.
Great. All right. Okay, any more questions? I know Justin wants to ask one more question about microdosing. Okay, Justin, bring it on. Does that
I love questions about microdosing.
Okay, here's a comment. Passing out xylazine and fentanyl testing strips have kept folks safe, but it's something we have heard in the Riverside County area. Okay, could this microdose also work for someone that will be admitted inside the hospital for a week or two and reports in the ED and has Cow's level is still not high enough to start a regular dose? Almost like a preemptive care.
Yes, that is the perfect patient for a microdosing protocol. Is the person who has a low cow that you're going to have access to for a number of days. So I love microdosing protocols, admitted patients. It's a really nice time to take advantage of that hospital admission to get someone discharged on buprenorphine.
Perfect. Okay, Justin, there you go. We hope we answered. Like I said, no bad questions. These are great, you guys. Keep them coming. I really love this engagement. Thank you, Dr. Moulin, too. So there's a myth about tooth decay with the use of meth as well. And I think, like Dr. Milan said, you have to also consider nutrition and hygiene, which people don't have access to. Yes, absolutely. All of it needs to be assessed, with the social determinants of health. Absolutely. And Justin says, good to know. Thank you. I'm not going to lie. I don't want anyone to go into withdrawals if not necessary. Absolutely. Absolutely, Justin. Okay. I have another microdosing. Is microdosing safe during pregnancy?
Yes, microdosing is safe during pregnancy. Great question.
Yes. Great to know. And then we have another comment. Lack of water dehydration leads to tooth decay as well. Absolutely. So with some great responses, some great statements, you guys. This is wonderful. We are done with this session. If nobody has more questions, we've divided our own kind of list of questions. Aimee, is there anything else you'd like to discuss before we turn into our Q&A?
No, and I just really wanted to say thank you guys so much for bringing this up, and please continue to give us questions, feedback, because as I said, like, we develop our guidance based on what you guys are seeing out there, and really appreciate it. So thank you.
Okay, and some of these questions we might have already answered because I know we've gone through a lot. So what can you provide for fentanyl patients to help with symptoms while waiting to start on buprenorphine? How long are we waiting after last fentanyl use?
Yes, so this can vary. Remember, we chatted a little bit about the longer duration of fentanyl. So sometimes patients need to wait, 24, 48 hours until their cows is high enough for the full macrodose start. And the other piece is you can send folks home with a comfort pack, or if it's just going to be a couple hours, keep them in the ED at UC Davis. We have an observation pathway for folks experiencing withdrawal where we'll hold them in the ED overnight, give them comfort meds. So some of the things that can be given are Zofran, clonidine, ibuprofen to help them, benzodiazepines to help with that anxiety while we're bridging them so that they can help feel more comfortable while their cows gets to a place where we can then macrodose with buprenorphine.
Great. Okay. Microdosing, I'm gonna skip that one because I think we did some service to microdosing today. Okay, how should you transition a patient from methadone to buprenorphine?
Yeah, so this can be a little bit tricky because methadone has a really long half-life. So, and folks who are on methadone will be often on high doses of methadone. So, ideally, that person will be transitioned down to less than 50 milligrams of methadone. And then what we want to do is hold the methadone for about 72 hours and then transition someone to buprenorphine. Those transitions can be a little bit tricky and ideally are sort of done in conjunction with their treatment program. Because methadone has such a long half-life, it lasts pretty long in the body. So we need to have that as a careful transition, and you really want to have folks kind of titrate back down their methadone dose.
Great. Thank you. This one we get a lot. Is there any medication for stimulant use, methamphetamine and alcohol?
Yes, great question. We are working on our stimulant treatment guide and updating that as well. There is no FDA approved medication for the treatment of stimulant use disorder. However, there are studies looking at medications that have shown to help people kind of manage their withdrawal symptoms and are associated with decreased methamphetamine use. One is mirtazapine or Remeron, which is given at night and helps with that meth sleep disruption. So it helps folks kind of deal with the sleep disruption that they have a lot of times during methamphetamine stimulant withdrawal and has shown in studies to decrease methamphetamine use. Other medications, naltrexone, which is that long acting sort of Narcan type agonist medication, but also helps with cravings for non opioid medications. Works very well and has been studied with antidepressants like Wellbutrin. So naltrexone plus mirtazapine at night, Remeron for sleep, or Wellbutrin, which is another antidepressant. So kind of the combinations that have been working for meth use disorder is that combination of naltrexone and an antidepressant. Primarily what we are doing at UC Davis is mirtazapine. Some of the researchers we've talked to feel like that's the best data out there. For alcohol use disorder, naltrexone and acamprosate are both FDA approved medications to help treat alcohol cravings. And we do have a protocol on the Bridge website for alcohol use disorder that is primarily helps with dosing for naltrexone and gabapentin. Naltrexone has a really cool formulation, which is an injectable that is covered by Medi-Cal and can be covered by Medi-Cal from your emergency department. So if there was interest, you can get the long-acting naltrexone on formulary so that folks who are experiencing alcohol withdrawal for alcohol use disorder, do not have co-occurring opioid use disorder, can even get the long-acting injectable naltrexone from the emergency department.
Thank you. Thank you. We have a question about what can I do if I do not have a champion to advocate for me?
Yeah, this is the hardest part because you're out there doing the hard work on your own. And I think it is important to have that community. And if you don't have that community in your hospital, please, that's what we're here for, to provide you that community so that you don't feel like you are alone, because it is hard out there being the change maker by yourself. It's really important to have friends and allies. And if they're not there in your department, please let us be your community of support so that we can help you be that change maker. And that's the other reason why we're trying to be here, to have these clinical protocols. So even if you don't have someone who is your champion, who is your cheerleader, who is helping you, that you can provide and give them those resources, because I don't want you to be out there and be the lone voice, just to be able to say, hey, California Bridge is providing the evidence-based guidelines, and here, if you don't know, here's a resource to do it. But I recognize, that is the hard work that some of y'all are doing out there on your hospitals, and we want to be here for you to be your support community.
Great.
And let us know, because, sometimes we can round someone up.
Yes, absolutely. That's what we're here for. We're here. We're working with you. We're your supporters. We took a lot of questions during the presentation, so we have 5 minutes left. We're not going to get to the second slide of questions, but some of them have already been answered. I did want to just address Justin's comment. Why has it been hard to find MAT providers that use Vivitrol and/or in the hospital itself?
I think Vivitrol is expensive. So Vivitrol is expensive if it's not covered. It's not covered for inpatients. There's this neat little quirk where it is covered from the emergency department as an outpatient medication. As soon as someone is admitted to the hospital, it is no longer covered, and it costs the hospital a couple $1,000s. So that is one of those barriers. But in the emergency department, it is covered by Medi-Cal. So it could be that your hospital hasn't looked at that little differentiation. Because I do think for alcohol use disorder, it is good to be able to offer that to your patients, because it does help with cravings.
Great. And then we got one more question in the chat about when is that meth guide or algorithm coming out, Aimee?
The meth guide, I think, is in production. We have a really important vetting process, which we do through California Bridge, to make sure that what we're putting out works for everyone. And so we're still in the process of collecting the feedback and then making it all bridgified and beautiful and easy to read.
We love it.
We spend a lot of time taking out extra words and extra steps so that our protocols are easy to implement in the super fast-paced environment of your emergency departments.
All right. So it's coming soon, coming very soon, you guys. I know, just be
Stay
patient.
tuned.
Stay tuned, right? That's for another round of training. Definitely we will have that training when that comes out. We are going to skip over the second page here, and we're going to, if you don't know resources, just log on. Our website is tons of information for you. We would like to thank Dr. Aimee Moulin for sharing this wonderful time. This has been amazing, Aimee. Aimee was so great to say, I want to talk to them. I don't want slides. I want to hear what they have to say. And I have to say, this has been wonderful. It's been it has so much useful information, you guys. So this was all Aimee's idea of just having a chat and talking. So again, thank you so much for your time.
Thank you, everybody. Really appreciate your questions, your attention, and all the work that you are doing.
And as with any of our bridge training, if you're not on the academy, remember you can do your whole training and it stores your transcripts. So we want everybody to head to the Bridge Academy if you want to get caught up with trainings. You can contact us, mentors@cabridge.org. That's the only email you need to remember. You don't need to remember anybody else's. And again, here are your mentors. If you don't have a mentor, let us know, mentors@cabridge.org, to get connected. We are here for you. As Aimee has said, we're your supporters and we can definitely help. Thank you for spending time with us, and you will get your post-event email with the evaluation for your CEUs. Until next time, everybody, bye.